Okay, thanks everyone. So let's just jump right into it. I have no disclosures. This is going to be the outline for today's talk. We'll start by talking about racial and ethnic disparities in HIV and the PrEP Continuum. And then we'll go ahead and discuss the barriers that are present at different levels, the individual network level, the healthcare level, and the structural level, and talk about specific strategies that are being deployed to address them. And we'll mention a bit about PrEP equity during COVID. And FYI, I borrowed heavily from this fantastic review that was written by, these are authors from the CDC and Harvard Med School, published in the American Journal of Preventive Medicine last year. So feel free, I encourage you, if you want to explore more about these topics, they have this comprehensive table listing all of the studies. I just selected a few of them that I could not possibly include. So I chose and highlighted a few of the efforts and projects that are being done, but I couldn't be all comprehensive. All right. So I thought I would start with this poster. This is called The Future of ARV-Based Prevention, created by AVAC, January 2022. This was shown at CROI and during Jill Blumenthal's presentation a couple of months ago. It's very nice and exciting, right? It shows all the different oral pills, vaginal rings, long-acting injectable antiretrovirals across different stages, including phase 3, as well as what they call multi-purpose prevention technologies. I show it here because it's exciting to have all these prevention modalities, but from a public health impact, it's not going to matter much if they are not reaching those groups that need it the most. All right, so we're going to do the first question of the morning. And I'll direct you to go to pollev.com/AVRC sysadmin 479, as you can see there, or you can also text AVRC sysadmin 479 to 37607. Yeah, you can see the instructions there. And the question is, what is the estimated lifetime risk of HIV for Black MSM in the US? And you can see the choices there. And I'm going to give us a little bit of time, since it may take a little time to.
And I can see online the choices are in order and letter. So it's A, B, C, D, E.
Wow. It's working.
Well, I think you can share that online. I can't see the results.
Oh.
So you can just share with everyone what the.
Okay. Okay. No, but.
All
Okay.
right, this is all new stuff
Okay.
for us. Sorry you can't see them there, so maybe Gabe, you can
Yeah,
share
so
what people
the
did.
vast majority of folks, 63%, chose A, 1 in 12. And then 25% chose B, 1 in 27, and 11% chose C, 1 in 50. Very good. And we'll go over the answer here shortly. And then let's move on to the next question. What is the estimated lifetime risk of HIV for Hispanic Latino men who have sex with men in the US? And again, select your choices. This time it should go quicker because you're already in the system. All right. So it sounds like most people are selecting B, the answer choice B, 1 in 27, 62%. 31% selected C, 1 in 50, and 8% selected D, 1 in 98. All right. So shown here is the estimated lifetime risk of HIV diagnoses in US among cisgender men. This was presented at CROI again, and also presented Dr. Blumenthal's talk a couple of months ago. So here the CDC used data from 2017 through 2019. These are data from the National HIV Surveillance System. They used mortality data and census data to calculate risk. And you can see here the, hopefully you can see my mouse cursor. So the risk 1 in the number over each bar. And you can see, so the highest risk is in Black MSM, 1 in 27, followed by Hispanic men, the risk of HIV, 1 in 50. And this can be contrasted compared to the risk in white men, which is 1 in 171, and Asian men, 1 in 187. So a full order of magnitude lower risk. So this is just to remind ourselves, what is the goal of the ending the HIV epidemic? Remember that the goal is to achieve PrEP coverage, at least 50% of folks that need it by 2025, and to remain at that by 2030. So that's 10 years. How are we doing right now? Not great. So these are data from the CDC's most recent HIV surveillance report. This is 2021. These are data actually from 2019. So as of 2019, only 23% of people who could benefit from PrEP were actually prescribed it. And as you can see on the right, we have the breakdown by race and ethnicity groups. So PrEP coverage for white populations at 63% versus coverage for Hispanic Latino populations at 14% and Black African American at 8%. So the disparity is quite big. This is actually an improvement when these data, similar data were presented at CROI a couple of years ago. The number for Black populations was actually 1% and Hispanic Latino was 3%. So it's actually improved. But there are still these disparities that remain, and the root cause of these disparities, which we'll talk about in today's talk, have to do with systemic inequities, structural inequities, and systemic racism that operates through a very complex network of historical and contemporary structures, practices, norms, and policies that are present. So, and this is important because the goals of the ending the HIV epidemic, the federal initiative, will not happen without addressing these racial and ethnic disparities. So this is a study, modeling study that was done looking at they calculated the HIV incidence, the incidence rate ratios in Black and Hispanic populations, compared them against white populations across 6 cities in the US. These are the cities here on the left. And they basically modeled, they projected the impact of what they called this either HIV treatment and prevention current parameters versus status quo versus this ideal implementation, which would be basically the implementation of these city-specific evidence-based interventions scaled up to reach most of the target population. And what you can basically see as an example here for the city of Atlanta, Georgia, looking at Black HIV incidence versus white HIV incidence, is that there isn't much improvement. There's a little bit of improvement here. The green bar denotes the ideal implementation. So there's a little bit of a reduction in the incidence rate, but what we would want, where'd the cursor go? What we want to see is for this to be closer to here, right? This gray line is 1, so no disparity. And as you can see, actually none of them come close to that across the 6 cities for Black versus white. For Hispanic versus white, 3 cities come close to that, Baltimore, Los Angeles, and Miami. But overall, these without addressing disparities in healthcare access, there's going to remain these disparities in HIV incidence. This is important because implementing PrEP more equitably is required to reduce disparities in HIV incidence. And this is a very interesting study. I'll go through it with you all. This is another modeling study. Here, again, they projected looking at, looking at young Black MSM and white MSM in the Atlanta, Georgia region. And they projected the impact of the PrEP continuum for Black MSM using different scaling parameters. And basically what you can see, for example, is so relative to the no PrEP scenario, this is the top row here, when you input into the model the parameters of observed Black MSM, you see a nice reduction in the HIV incidence among Black MSM from 7.73 down to 5.88, hazard ratio of 0.77. So that's a 23% decline in the rate of HIV incidence. And accordingly, the absolute disparity also decreased from 6.08 to 4.95. Now, if you increase the parameters of the model to that of observed white MSM, then you see an even greater decrease in the incidence among Black MSM. This is the outcomes are at 10 years. So this is 4.15. So now it's a 47% reduction in the incidence of HIV among Black MSM at 10 years by 2030, with an associated reduction in the absolute estimate of the disparity down to 3.3 per 100 person years at risk. What's interesting here is these relative measures. So what you can actually see is that the relative disparity actually goes up compared to no PrEP if you take when populations take PrEP. The reason for that's because this relative measure is sensitive to the denominator. The denominator is white MSM incidence as a function of their PrEP use. So it's actually not till the individual level benefit of PrEP for Black MSM is greater than for white MSM. So when this prevention index goes less than 0, that you actually see a reduction in this relative in the relative disparity from 4.68 now down to 3.97. So overall, effective PrEP care for Black MSM would need to be equal to or greater than for white MSM to achieve a reduction in the disparity on this relative index, which I found really interesting. Okay, so now we're going to talk about barriers, and the next poll question is here. So if you could get yourselves ready. Which of the following would not be considered an individual or network level barrier to PrEP access? A, lack of awareness about HIV and PrEP. B, concerns about side effects. C, competing priorities. D, lack of insurance. E, stigma. Or F, social and sexual networks. Okay. So most, I'm not doing that, am I? Hope not. Okay, so most folks selected D, lack of insurance, 45%. And we'll talk about that in a second. So listed here are going to be the individual and network level barriers. So the individual and network level barriers work on 2 levels, on the intrapersonal level and intrapersonal, meaning knowledge, attitudes, beliefs, and practices around HIV prevention and PrEP generally, and interpersonal factors, relationships, and social interactions. So specifically, these barriers, what are they? So lack of awareness about HIV and PrEP, especially about its efficacy, lack of knowledge about its safety. There is evidence in the literature that there is an actual discordance between actual and perceived HIV risk, especially in Black communities. Concerns about side effects could also be a barrier to PrEP uptake. Competing priorities. So, and this is important because we're talking about a prevention modality, right? That needs to fit into people's lives, needs to compete with food, shelter, employment is a big one, you know. Stigma. So HIV, stigma can be complex. There can be HIV related stigma. There can be PrEP related stigma, heterosexism, medical mistrust, racism, and many of these things operate on both the individual and network level. And then finally, social and sexual networks, which they can guide a person's norms about PrEP use, PrEP or no PrEP use, depending on their network groups. Okay. Yeah, Darth. Thank you. Darcy just said physician level also, and actually that's going to come later, that they can also serve as a barrier from the physician standpoint also. Okay, so strategies to address these barriers. So most of the efforts have centered around three major topics in this area. One of them is navigation through the PrEP continuum and navigators and navigation. So HPTN 073 was a PrEP demonstration project. And in this project, they offered PrEP to Black men who have sex with men alongside a theoretically principled, culturally informed, client-centered care coordination model. And in this study, 226 people that enrolled, 79% initiated PrEP, which is pretty good. And of these, 64% still used PrEP at week 26. So based on these results, there was a randomized controlled trial pilot study for young Black men who have sex with men that implemented a culturally tailored PrEP counseling center that was staffed by Black MSM. And it did pretty good. So after the counseling session, they were then kind of referred to a PrEP provider. And in the intervention group, 6 people were still taking PrEP at 3 months compared to 0 in the control group. So a couple of different groups have already, and jurisdictions have already worked on this. So the Washington, D.C. Department of Health, they hired and they embedded local community members as PrEP navigators at their STI clinic and community-based organizations to connect men who have sex with men and transgender women of color to PrEP. And they were able to screen more than 3,000 people and linked more than 35% to PrEP, which is good headway. The city of Chicago implemented a phone support called PrEP Line. It is a phone support line to assist Black MSM, transgender women, and heterosexual women with navigating the PrEP continuum. And they generated 566 encounters, of which 31% initiated PrEP. So that's very good. And part of the reason that they attributed the success was that this was embedded within a larger citywide sex-positive PrEP marketing campaign for Black MSM, transgender women, and heterosexual women. And you can see an example of one of the ad pictures on the right there. The larger campaign was called PrEP for Love. So there's also stigma, and this is a big one. It's a complex one. And here I can highlight one of our very own, Dr. Laramie Smith here at UCSD, and her Nexus study, which examines intersectional stigma among Hispanic Latino men who have sex with men and its effect on HIV prevention. This is a partnership with the San Diego LGBT Center and San Ysidro Health Center, and it's currently enrolling. Another big group of interventions fall under the peer and social network levels. This was a pilot social network level intervention among Black men who have sex with men in Milwaukee. And here they identified 5 community social networks. The sample size was 40. And they identified persons that were the most interconnected in these networks, and they trained them to endorse PrEP use to others in their social networks. And these are the results. And basically, these are changes in PrEP outcomes from baseline to 3 months. And you can see actually that the change over time was good. There was an increase in PrEP knowledge, in PrEP attitudes, in norms, and in willingness to use PrEP among the intervention group. This is another study. This is called PrEP Chicago, that is training young Black MSM as peer change agents to use social media platforms to increase PrEP uptake in Chicago. And this is a randomized control trial that is in progress currently. This is another one, ePrEP. So this study involved young Black and Hispanic Latino men who have sex with men in designing the intervention. So in this study, they had influential peers themselves lead a 6-week social media PrEP uptake campaign with friends that they recruited. And in a cluster randomized control trial, the peer-led intervention increased PrEP knowledge and decreased stigma. Another shout out is to one of our own. This is our own Dr. Heather Pines here at UCSD, and her study, Open, Onboarding Positives and PrEP Users to Engage Negatives. Similarly, an intervention to train young men who have sex with men of color to promote PrEP among HIV negative young men who have sex, young MSM of color in their social networks. And this is also similarly a pilot randomized control trial to evaluate acceptability, feasibility, and the preliminary effect on PrEP care engagement. And this study is enrolling. The other big bucket when it comes to interventions in this category are mHealth interventions. So the utilization of technology, devices, smartphones are now ubiquitous. So researchers are really trying to leverage what they can do here. This example is of a St. Louis-based, community-based organization. They very smartly created this a profile on a geosocial networking app to address sexual health questions. And over a 13-month period, it was very nice. 98 people engaged. Out of them, 11 were eligible for PrEP, and 6 were ultimately linked to PrEP care. So even though the number may seem a little bit low, still, these are people that perhaps would never have been reached through other conventional means. So there is actually a bunch of mHealth applications, mHealth app trials going on right now. And instead of going through them individually one by one, I just kind of listed them here and I'll just discuss them broadly. So most of them, as you can see here, so this is Links, I believe, is out of San Francisco, Boston. Most of these are either collaboration between Boston, or Emory is another big group that has developed these. And as you can see, most of them are based in theory-driven. So the framework is based in social behavioral theories. And they are mostly focusing on young MSM and sometimes young MSM of color, and they're randomized control trials. Most of them are mobile apps, and some of them are social media messaging campaigns. Okay, so are we doing on time? Okay. What are the healthcare system level barriers? So these are some of the ones that Dr. Wooten just asked about. So there are a couple of them. Some of them are clinician related and some of them are more like system related, but the ones that are clinician related factors. So there can be unconscious bias and overt racism. And even though they're different, they can be both just as impactful in the prescription of PrEP. Sexism, homophobia, transphobia, and this can work at different levels. The stigmatization of people with substance use disorders which can impact and mirror whether how the clinician perceives whether someone is at risk or deserving of prevention modalities. Lack of clinician awareness and knowledge of PrEP, and this is a big one, and we'll get into some of the projects that are being used to address this. And concern about risk compensation. So this could be another reason why a clinician may not want to prescribe PrEP, even though evidence has shown that that HIV incidence does not increase among PrEP users. These are factors that impact prevention and care service delivery that are not so much clinician associated. The miscreening for PrEP can happen at different levels, and even though there's guidelines for who has an indication for PrEP, ultimately these are operationalized at the individual provider level and clinic level. The purview paradox is the term for which clinical setting is most appropriate for PrEP. Is it a primary care setting where people may be unaccustomed to HIV or to antiretrovirals, or HIV infectious disease providers, which may not see folks that do not have HIV? And this has been going on for a long time. It can affect the lack of access to PrEP providers. And finally, mistrust of clinicians and health institutions, and this also can operate at multiple levels. All right, so what are some of the strategies that are being done to address these barriers? One of them is streamlined PrEP referrals and pharmacy-led PrEP, right? That initiation process. This is a project that was done at Durham County. This is in North Carolina. In their STD clinic, so their STD clinic did not provide PrEP, does not provide PrEP normally. And it primarily serves Black and Hispanic Latino patients. So they created a referral pathway to a federally qualified healthcare center in their jurisdiction for PrEP. And of 196 referred patients, 60% presented for an initial PrEP appointment, and 38% persisted in PrEP care for 3 months. And even though the numbers decreased, just the fact that these folks were able to be reached and able to be started on PrEP is encouraging. Another example of this is in Jackson, Mississippi. So a non-clinical HIV testing center, clients that presented there were referred to an on-site clinical pharmacist for same-day PrEP. And of 69 referred patients, 77% filled a prescription and 43% attended a clinical appointment. The number, as you can see here, does decrease when you look at those who attended a clinical appointment, but the focus and effort here is more centered on the initiation process. Similarly, this is an experience in Denver. Their Denver Public Health Department of Health STD clinic. They started people on a 30-day starter pack, and they were referred to a PrEP navigator for linkage. And in their experience, of 100 people who received the PrEP starter pack, 57% attended at least 2 follow-up appointments. And then finally, our own experience here at UCSD, the iPrEP study was based at the Good to Go clinic, and clients who presented for STI testing and HIV testing were, if PrEP eligible, referred to the pharmacist at the AVRC for 30 days of PrEP and a case manager for linkage. And in our experience, out of more than 1,200 PrEP eligible men who have sex with men, 456 were interested, 249 initiated PrEP, 209 were linked, and 67 were in care at 3 months. So you can see the PrEP continuum here, and you can see that there's quite a bit of a decrease along each step of the PrEP continuum. And it is actually in part as a result of this study that a newly funded study came into being, eSTEP. This is the PIs are Susan Little and Keith Horvath. And this is a theoretically grounded web app that is, so this is an mHealth intervention that is designed and tailored for Black and Hispanic Latino men who have sex with men and transgender women. And it's designed to improve the whole PrEP continuum. So each stage of the continuum, where we see such stark drop-offs. And the outcomes of this are going to be feasibility and acceptability, as well as PrEP initiation, adherence, and appointment attendance. And this is going to be piloted at the ON clinic, so more to come. Another strategy that can be used is simply increasing the number and the types of PrEP providers. So Project ECHO, some of you may be familiar with, this is a telementoring model that was used to expand hepatitis C treatment access in New Mexico. So it was used, this is Joanne Stackler at the University of Washington. They used it to support PrEP prescribing by community practitioners, and overall the experience was good. Participants, community practitioners, reported that it helped them stay current on PrEP guidelines, improved PrEP knowledge, and it increased the likelihood to prescribe PrEP. Academic detailing is another modality that was mentioned, and this is basically using trained representatives to do outreach to educational outreach to clinicians in their practices. So this was used to increase PrEP knowledge. This was a 3-year detailing effort that was done by the New York City Department of Health, and it reached more than 2,500 clinicians and increased the number of new PrEP prescribers. So encouraging. Telehealth-based PrEP is also very prominent. For-profit apps have been around for a while, but one important concern is that as telehealth scales up, that it does reach the populations that it needs to, or that it's going to widen disparities. So one of the studies that served to specifically address that question was the PrEP study out of UCLA, and this is they enrolled 25 young men who have sex with men. They did telemedicine visits, home delivery of PrEP, and STI testing kits. And 21 out of 25 initiated PrEP, and most of them felt that it was confidential, fast, convenient, and easy to use, and very low levels of PrEP stigma were experienced. So this needs to be further cost and risk and other factors still need to be studied. Another strategy is home-based PrEP and mobile vans. So these are the first one is this PrEP at home. The PrEP at home was based out of Emory, and basically an intervention. All the testing kits and needed supplies are sent to the person's house address. This was a big feasibility study, and overall the intervention was rated as acceptable or highly acceptable by the participants that enrolled in the study, and more than 85% stated that they would use PrEP at home instead of standard routine PrEP visits if it was available to them. ePrEP is another study, I think also, by the same Emory group, Aaron Siegler. It is similarly home-based. It's a mobile app, self-collection testing kits sent to the home. And the interesting thing about this one is that it's focusing on non-urban young Black and Hispanic Latino MSM. So most of the interventions so far have focused on urban centers, which is where a lot of the incidence is occurring. However, non-urban folks are still at risk, and they have far fewer resources. And then finally, this mobile van effort out of the University of Miami in Miami, Florida, PrEP on the Go. They had a multilingual team that partnered with a community-based organization for social media ads to recruit them to come to their mobile van. And it did pretty well. 166 out of 168 eligible individuals initiated PrEP. And that was nearly 80% of them were Hispanic Latino, and about 74% of them were foreign born. So this is a very nice proof of concept that mobile vans can indeed reach difficult to reach populations and still be culturally relevant. Yeah, Darcy was saying that it's the rate of the initiation seems higher than some of the other interventions that I mentioned. Yeah, it could have to do with the social media ads that they place and the fact that they, the presentation, of coming to the mobile van as opposed to the outreach of the home testing. Okay, so structural level barriers. These include financial barriers, and this includes insurance, this includes out of pocket costs. And these can be real or perceived, right? People may not be aware that they have resources available to them. Distance to PrEP providers and lack of transportation. So we know actually that there's a lower density of PrEP providers in communities that have higher Black and Hispanic Latino populations. And lack of transportation works similarly. Policy decisions, so the expansion of Medicaid and jurisdictional PrEP assistance can impact the assistance and access to PrEP in individual jurisdictions. Immigration status and limited English proficiency, which can actually impact both Hispanic populations and Black immigrant populations, of which we have big communities here in San Diego locally. And finally, medical and government distrust, which can operate at multiple levels. Okay, so what are some of the strategies? So there are PrEP assistance programs, and unfortunately, these are not universal, right? They vary state by state. And here in California, we're lucky that our PrEP assistance program covers many things, associated tests, associated labs, associated vaccinations. Not all states have that luxury. Insurance coverage expansion. So the expansion of Medicaid can impact access to PrEP. And actually, in one study, it was shown that Medicaid expansion was associated with a 5% decrease in the rate of new HIV diagnoses. And then finally, the advent of generic tenofovir and cabotegravir. So both of these now, as they're coming on the market, we'll have to wait and see whether these can be utilized and leveraged to further increase access to all populations. So we'll have to see. And then I'll touch on PrEP during COVID. When COVID first started, prevention services were shut down for a moment, and even STI clinics were shut down for a moment. And so the CDC came out with these recommendations. Number one, ensuring PrEP availability for all patients is important. Number two, continuing quarterly HIV testing through lab-only visits or HIV self-test collection. And finally, extending PrEP prescriptions to 90 days. And some clinics may have already been doing this, but at least these are a few key modalities that can be stressed to further improve access during COVID. And finally, telehealth visits where feasible. And because of COVID, most healthcare systems implemented some type of scale up of their telehealth operations. All right, well, to conclude, so barriers to PrEP uptake operate across individual, network, healthcare system, and structural levels. And to reach the goals of the federal initiatives like the Ending the HIV Epidemic, the federal government, health departments, and academic and community partners must implement innovative programs and policies that can help tackle these barriers. At the same time, really, this is going to need broader structural reforms that address the underlying social, economic, and political determinants of health, because this will be key to addressing the disparities. And with that, thank you to Joe for reviewing my slides and Susan for her summary on the study. And I'll take questions and comments. Have there been any questions from the chat?
It's been really quiet. But I think this is the whole point. Now we get to have a lively discussion. So anyone in the room, I can get us started, if that's all right. So Gabe, first of all, great presentation and excellent summary of what's happening right now. So a lot of the interventions, I think Darcy hit on it well, really don't, it seems like there's a lot of work to get to just a few people. And that's just mostly for uptake, and we've talked about what happens further down the line, retention always drops off. So it still feels like we're doing a lot for, maybe a big squeeze for little juice. Why do you think that is? And what do you think we can do differently?
So I think there has been, when you look at the PrEP Continuum cascade for a couple of, well, it depends on the type of study that they are, but yes, we have known for a while that there is steep drop-offs in in long-term PrEP persistence. I think just now we're probably starting to take a really close look at how to improve that. Susan's E-STEP study is a good example to looking at just culturally appropriate ways to maximize each step of the continuum. That's one thing. Reaching folks in the community that are hard to reach already is challenging. And a lot of these interventions are very kind of far apart from each other. So in the future, the coalescing of, for example, a mobile van linking someone to a culturally appropriate mHealth intervention, something like that could be done with time, that can help to improve the continuum. But I think we're getting there. I think it's just taking a long time. And by way of background of all the how complex these disparities are, you can see that it's always going to be challenging. It's always going to be an upward hill just because of the systemic inequities that exist.
Thanks.
Hey, Gabe. So, as far as, and I know this isn't exactly, this is maybe looking back earlier in the continuum. So as far as providers, one of the things that was a big issue up until recently, I don't know if it's changed, is that there's not any education for new physicians through school for any sort of LGBT or preventative care. And so I don't know if in like recent years, if UCSD has changed the curriculum to be more comprehensive, so that it's more proactive instead of trying to retrain providers after they go into practice.
Well, actually, we have Darcy Wooten here, but so yes, well, I guess my experience, of course, my exposure is to our own local School of Medicine, where Jill and I have been involved in healthcare elective for looking at intersections of LGBTQ health for some time, and there's efforts now to incorporate that into more the mainstream core curriculum of the medical school. But that's UCSD. So the question is, how much of this happening across the board? It does seem like there is more awareness and there is more efforts to be inclusive, to include this education at multiple levels, starting from the medical school level, because it is important. We were talking about clinician related factors, and actually research interventions are specifically looking at now, not so much, there's the education piece of it, but there's also, like, on the research side, they're looking at interventions to actually address how best to modulate the on the clinician side, how best to address these gaps in PrEP prescription interventions to go about it, looking at socio-behavioral aspects of the clinicians themselves.
Yeah, and I think you touched on it, right? As long as it's an elective, it's not gonna work, because the people that are interested in it already know about it, and the people that are interested in it aren't going to hear about it.
Exactly.
So,
Darcy, yeah.
I forget what the program was, but I was on a panel for like LGBT issues for And Darcy would know what it's called, but it's like all the UC schools have like kind of have an education week sort of thing. And it was down here and two people showed up, right? There was like elected, like they could kind of choose which ones to go to. And of, I don't know, the 100 or so people, two people showed up. So.
Before I give it to Darcy, I'll just comment that for our residency, things are not, they are mandatory. So everyone, there's now a gender health rotation, and I know this is past med school, but Darcy can talk about that. They all have to spend 2 weeks doing a gender health rotation, whether they like it or not. And I think it offers great exposure for them. But again, this is UCSD, and I think we actually are quite ahead of the curve. So that's also part of the problem.
I'll just, oh, is it on? Can you? Okay, so I think the key thing, and we need more medical education literature on this, is that education doesn't translate into practice one-to-one. And so LGBTQ care, including prevention, is part of the core curriculum in medical school. And I think actually medical students are more passionate and very interested in this topic. And then I think what happens in training as they go into their specializations, and it's not my lane, so to speak. And so some of that is lost. And part of that, right, is that we need continuing medical education for people outside of our field who are teaching these people and are the mentors for these people to model for them. So I think figuring out how to do more than like, let's just give a talk on PrEP and then think that everybody will now prescribe PrEP. Like, how do we actually improve our education processes to lead to change in practice is an area for improvement. And then also kind of, again, trying to expand this and continue this on throughout beyond just medical school training. The other thing unrelated to this, but related to education, that I had a question for you, Gabe, is like, is there any role in primary education in terms of adding, PrEP education at the elementary school level, junior high level, that type of thing? Just thinking about, of course, right, kids are all in school for the most part in terms of impacting disparities, and that's a way to maybe reach more people and get people interested, understanding, and aware, and also sort of this addressing this risk perception idea. So is there any role or what's being done there? Do you see that as being important in terms of sort of incorporating PrEP into sort of standard sex ed that takes place across the country?
I am not too familiar with actual PrEP educational efforts like nationally and like at the school level. I can tell you that public health PrEP campaigns they try to target the populations that are most affected. So as you saw with the PrEP for Love, but they do that in like they try to set out a wide net to communities in general. But as far as like actually like a nationwide, like a school curriculum, it comes also down to policies, politics. So, any efforts like that would have to, be considered, yeah, against that. Yeah.
Gabriel,
Yes.
fabuloso. I really enjoy your talk. Thank you very much. I want to throw a thought for everybody's, because really the issue with education, sustainability, implicit bias, generational gaps, even within infectious disease field and HIV medicine field is huge. Impact the way how we approach and how we care for people in need of PrEP. And I don't need to comment on the challenge political situation in our country. The issue is that right now, PrEP, in addition of lack of systemic education across the country, training, it doesn't have a niche for practicing. It is assumed that infectious disease might be more lean, proactive, and those who practice HIV medicine to embrace and take. It is hoped that primary care doctors and family practitioners will also be part of the force. In reality, it doesn't work in that way. So, like with HIV medicine surface, it became its own standing branch. The only way how this will continue be developed, supported, advocate, policy development, stakeholder involvement is really by creating a force where gender health equity becomes like a little bit of its own group of experts branch that start attracts more sustainable people and also promote policy development. That's just a thought for everybody because we all are favorably biased towards the vision. When you actually even walk out UCSD within our county, the perceptions and the realities are different. And the final thought is really, there are disparities everywhere, right? Outside HIV, cancer screening, cardiac disease, you name it. And we all try to be embracing silos, development of projects to improve different strategies. But what it tells me is that really we need to do more at the bigger level. So the resources are deployed more efficiently and the problem is tackled more proactively. Thank you for that thought, Gabriel.
Thank you, Lalo. Yeah, oh, good. Sorry, go ahead.
Thanks, Gabe. I think, and you mentioned it, but I think one thing that cannot be overstated is insurance. And, I think because when we see new diagnoses, we're always asking if you've taken PrEP before. And overwhelmingly, the people that had taken PrEP before and then do get infected, they stop because of insurance. And they lose their insurance and then they no longer access care. And it's not necessarily, and in California, we have the resources, right? We have PrEP apps. So, one of the, I think it's one is just, there's still a lack of education about what is available in terms of resources to access PrEP. And that's in California where we have this stuff, in other places where they don't have programs like PrEP app. Because I think a lot of these interventions, I suspect, often provide the PrEP without insurance and things like that. And so if you really want to think about realistic scale up, you have to think about how to continue to actually allow access from an insurance perspective for large groups of people. For PrEP, about 60%. It was 75% at 3 months, about 60% at 6 months, and 50% at 12 months.
Yeah, insurance.
That is sort of where a lot of places land. And of course, sorry, I'm not including anyone, especially now. Everyone is home, sorry. No, and our, we have a clinic that's predominant, and we have a lot of people that have PPOs, but then we also have a lot of people. Sorry, we were talking about our clinic at Owen, which our rates at 6 months retention are about 60% and 50% at a year. But we also serve a population that is predominantly white. We have a lot of PPOs. We do have Medi-Cal, and about 30% of people use the PrEP assistance program. But in terms of what we're trying to achieve here and what Gabe is talking about, we're not necessarily improving that. And we've talked about that, how, our clinic, we hope we're not widening disparities by what we do, but we're certainly not getting more people in the door who we really want to be.
Yeah, there is a federal, the Department of Health and Human Services instituted a federal PrEP coverage program, Ready Set PrEP, it's called. And they recently, last year, added a mail order option for that to increase access for those that don't have insurance, especially for the tribal lands and jurisdictions like that. But again, it also has to do with awareness and whether people are aware of these resources.
so many of these programs, including Ready Set Prep, are just for the medication. And the medication is just one piece of this. They are not covering labs. They are not covering visits. They are not covering STI testing and treatment. So that's, huge limitation, but obviously it's something. All right, people are asking questions, but it's 8:58 and we're going to cut things off. Okay, this was fabulous. We really do encourage more people to come in person, please. We are really trying to get back to the normalcy of life, and it's nice to be together. So if you can, please do that. Sorry. Thank you.
Thank you.